has a history of vomiting and drooling, and on abdominal ultrasound they found a foreign body in the small intestine. In addition, they found a mass in the spleen, and so we're going in for an exploratory to identify where that foreign body is, hopefully to remove it and also to do a splenectomy. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So again, this is an 8-year-old fox terrier, history of vomiting and drooling, and on ultrasound they found an intestinal foreign body as well as a splenic mass. And so we're going in for an exploratory to identify where the foreign body is, hopefully remove it, and also to do a splenectomy. So midline linear approach. So when we do an X-flap, we want to make sure that we go all the way up to the xiphoid, which is right there, and at least down to the prepuce in male dogs, somewhere between the umbilicus and the pubis in female dogs. All right, and then the next thing is that we always remove the falciform, because it's going to increase our visualization. We talked about just doing sampling of the splenic mass, but the owners were concerned that if we found that it was cancer, we'd have to go back in and remove it, which is fair enough. In Singapore, there are some tick-borne diseases that can run amok if you remove the spleen, but this owner felt that since he's been an indoor dog and been very well up until this point, he decided to go ahead and have the spleen removed anyway. So next thing, we want to make sure that we don't entrap any intestine or any vital organs with our Balfour retractors. I can already see a dilated loop of bowel. I can see a splenic mass. All right, so I'll just open this right up. And then I'm going to get some more towel clamps and towel clamp this Balfour in, because I don't have a spoon on this Balfour. So, all right, so now when we do exploratory, the first thing that we do is look at the diaphragm, make sure that we check for any hernias, and I have picked up incidental diaphragmatic hernias before during an abdominal exploratory, so we can't just pretend that we're looking at it, we actually have to look all the way through it. The liver looks pretty good. I'm looking at all of those lobes, left middle, left lateral, quadrate, right middle, right lateral, and we'll look at the caudate lobe in a minute. Now we're going to run the, you know what, can we get that ligature? Just get that spleen out of the way. All right, so now we're going to palpate the stomach, particularly the cardia, to make sure that there are no masses. I can feel some food in there. Pylorus, and then I'm going to use the duodenum as a retractor. And looking down in that basket, I can see the pancreas, I can see the portal vein, I can see the hepatic artery, I can see the right kidney, and I can feel the right adrenal gland, and I can see the caudate lobe of the liver. now coming around the caudal duodenal flexure. Remember that we can't exteriorize that because of the duodenal colic ligament, but I'm going to palpate around the corner. Let's get some moisten lap sponges, please. And so I'm palpating around the corner. You can already see that the intestine's starting to get a little bit dilated. So into the jejunum. A little bit of trouble getting my fingers around it. Here we go. So that's jejunum there. I'll go ahead and lay that on top, please. And you can see that the jejunum is starting to get a little bit floppy. See if it's got some peristalsis. So the way that you induce peristalsis is to pinch the bowel, and it should induce a peristaltic wave, and so that has got some pretty good ileus. All right, so I'll take a towel and zoom out a little bit. And again, the intestine, the farther we go, the more dilated it is. We've got a foreign body sitting right here. Okay. So it looks like a little piece of plastic or something. The intestine, while it looks dilated, I'm going to run that again to make sure I didn't miss something, because I don't feel like I ran the whole intestine. So back down to caudal duodenal flexure here. So I did run the whole thing. All right. Can we get a couple of moisten lap sponges, please? All right. So any evidence that it's perforated? It has not. And ideally, I don't want to cut right over the foreign body, but it's pretty big. I'm just worried that if I try to milk it along, I'm going to do more damage to the intestine. Looks like it's almost thinking about perforating right there. Okay, so we'll just pack this off. Do we have any Doyen intestinal forceps? No, that's a caramel. Yeah. I beg your pardon? Yeah. Very cool. You're just waiting for the Doyens? Yeah. All right, so I'm just trying to milk out some of this stuff out of the intestine while we wait for the Doyens. Can I get some 4 PDS when you get a chance?
Yeah.
We're just using our Doyens to keep, or to minimize the contamination of the abdomen. Awesome, thank you. And when I put on the Doyens, I just do one click. No reason to crank them all the way down. And then we'll take some 4O PDS and put in some stay sutures.
Thank you.
So go ahead and put that just below. Yep. And lay that down over here. I don't think this is too far off. I think I've lost my 4O PDS. Oh, no, I didn't. I don't think we're too far off from perforating. Yeah. So it's a good thing we've gone in. All right, so let's just get suction ready, please. Still not sure what this thing is. Perhaps a ball? I'm not sure. Some kind of toy, yeah. It smells not so good. Keep suctioning for me, please. I think a little bit of intestinal mucosa that it's dragged along with it.
It will be okay.
Yeah. Yep. Okay, so I'll get you guys to just retract on these two. So we'll keep a bit of tension on those. So it's nice and vascular. There's a lot of blood coming out, which is nice. Do we have a little mosquito? A little rat tooth? So I'm going past the end of the enterotomy a little bit. So does anybody who's watching know what the risk is for dehiscence and peritonitis with an intestinal foreign body and an enterotomy? What's the risk of dehiscence and peritonitis with an enterotomy? I'll have you retract on that guy now. So I'm going about 3 by 3 here, meaning that I'm going 3 millimeters away from the edge and 3 millimeters apart with each of my bites. And you can release that stay suture and just keep holding on, just keep trailing my suture, yeah. And so by maintaining tension on this trailing suture, so So there's one comment that's 15% risk of dehiscence, and that's exactly right. So it's quoted to be 7 to 15%, and I always quote that upper end of the range. And the biggest risk factor for post-op peritonitis and dehiscence is pre-op peritonitis. And then the other one is if you're going in for cancer or a foreign body, is the other big risk factor. And then things like hypoproteinemia, drugs that affect wound healing like chemotherapy and steroids, poor nutritional status, hypotension, all these things that we commonly see in dogs and cats for which we are doing an enterotomy. So you see how Hana is keeping tension on that trailing suture, and that's really important to keep from having loose suture loops. Now what's the next thing I'm going to do after I finish closing my enterotomy? Any ideas what the next thing I'm going to do when I finish closing my enterotomy is, guys that are watching? I think there's a question there. Can you read that question, Anissa? Yeah, so I always go full thickness. Using or suturing omentum to the surgery site is going to help reduce the incidence of infection. I feed them immediately after surgery as soon as the dog's willing to eat. This dog's a Jack Russell or a Fox Terrier, so I think he'll be eating pretty quickly. I usually send them home the day after surgery because I feel like they're less anxious and stressed and they're more likely to eat at home. If they're going to dehiss, it's going to happen in hospital, or in hospital just as likely it is to happen at home. So I just have the owners observe really closely. If the owners are particularly worried and would prefer the dog to stay in, we're happy to do that, but generally I like to send them home as soon as I can. It's pretty much for everything. I'm a big believer in getting patients home. Now I don't leak test these, as you guys probably are aware, but I am going to probe with the tiniest little mosquito hemostat I can find. I'm just going to clean that up a bit. I reckon that looks really good. Like you're not going to get much better than that. Yeah, that's just great. Really happy with that. So we can go ahead and take those out. Yeah. All right, so we've removed our stay sutures. And now I'm going to remove my doyens. Take one more look at that area that I was concerned about pre-op, or pre-enterotomy, and that looks heaps better. All right, so now we'll just get a bit of momentum. What I might do is do my splenectomy first, and that'll be easier than to identify my pedicle with momentum. So just hold on to that spleen, and we'll just feed the vessels into the ligature. Let me just zoom out. Anissa, when I get the spleen out, can you read that question to me, please?
I'll sit right now. Once it's out. Once it's out.
After I get it out. I'm concentrating right now.
Yeah. That's what I thought you said, but I just wanted to make sure I didn't leave you hanging.
Didn't want what?
Leave you hanging.
I'm building tension. It's an old Hollywood trick. Keep them hanging. What's going on here? Here we go. Once I get this out, I can look down in the colonic basket and just make sure the adrenal gland is normal. This is one that we do not or did not have a CT scan before surgery, so it's particularly important that we do a good exploratory. Okay, so now looking down here, I can see my left kidney. My left adrenal gland is just sitting right there. All right, so that's good. All right, so now we'll just take a loop of omentum.
Should I open a new posterior spec?
Yes, please.
Vin. Sorry, can we get the polio round PDS first? Posterior round PDS. Thank you.
So what was the...
Well, there were two, but the one that I half read still is it. I remember it said you mentioned that it was about to perforate. So the question was, what are your criteria
resection?
for resection versus?
Yeah, so if I feel like there's necrosis, and you know, once we took that foreign body out, the appearance of the intestine really improved. So, and the color was good. It was nice and pink, and so I didn't feel like there was any risk of further perforation. If that had not been the case, that's when I would think about doing an intestinal resection and anastomosis. And I'm just going to hemostat this tag. Yep. And I always get asked this question, can I just drape the omentum over the enterotomy? And I can, but I just figure why not give it that head start and suture it on. It takes me 5 minutes to do that, and it's not like it's going to make a proper seal, but it is going to bring in blood supply and help with healing. Do we have warm saline coming?
Yeah.
Let's see what we've got here. And these bites from my omentalization are full thickness. Don't have to be, but that's what they usually work out to be. just gone all the way around with that, and then I'm going to tie it to my original tag. Just makes it a little bit easier. All right. So it is interesting, the ileus that we have going on here, and I'm going to pinch that bowel again and see if we get anything. Maybe a little hint of some peristalsis going on there, but not a really nice wave. See, it is blanching. Maybe it's starting a little bit. We've got nice pulses everywhere, and the intestines look nice and pink. All right, so let's take out these balfours. And we'll use our towel clamps for retraction while we flush. All right, go ahead and pour that in. And lift that up a little higher. Can I get some 2-0 PDS on a taper? Now we're starting to get some contraction here, just from the water coming in, so that's encouraging. Okay. 40? Perfect, thank you. That is one of the coolest things ever, is using that gun from the hardware store to measure the fluid temperature. That is so good. I cannot believe that I never thought of that. I can believe I never thought of it. I just can't believe nobody ever told me. So foreign body in the distal jejunum. What's that? Yeah, so you can watch the video if you'd like later. Yeah. All right. Can I get a larger needle driver, please? Just so I don't wreck this one. Ligashore, regarding settings, we just have it on automatic, so I don't set anything. I think that there are 3 different settings you can put the Ligashore on, but we don't change it. It's just on auto. What is that? What's that? 37.4. 37.4? Yeah, that's fine. Pour it in. I think it's part of a toy. Looks almost like a turtle shell. So I suppose it could be a toy turtle shell. I'm not sure. Oh, I've got fluid running down my leg. Is that your fault?
I got some charge for holding up now.
Okay. I just want to get see how delicate these needle drivers are. And so you want to take care of your instruments. And so I'm just asking for some bigger needle drivers that are less likely to get damaged by my grabbing that big needle. Yeah, the engraved saline pan is very cool. It's a really good touch. I had not. Yeah, I had not noticed that. Thanks for pointing that out. Now I'm going to have to get some.
Can't be beat.
Yeah. 2 YouTube channels. 60,000 subscribers.
Wow.
What's that?
That's really cool.
One of our emergency vets has just discovered that we have a YouTube channel.
This is the kind of videos that you usually look at before the surgery.
Yeah.
You open the textbook and then they open this video and they're like, okay, tomorrow we'll do this or something.
So I'm just getting the external rectus fascia. Don't need to go all the way through. Thank you. You can go ahead and take those out, please. Thank you. So what I'll do is when I'm finished suturing the linea, I will have Hannah take over. And I'll go and make sure that there aren't any unanswered questions on the stream. And then because Hannah may be a little bit shy, I'll turn off the live stream.
Thank you.
Now we might have a thymoma tomorrow, so a thoracotomy. And I will try to live stream it if I can.
How many do you need?
But I have to get permission from the owners. Well, first we have to get consent for surgery. And then I have to get permission from the owners to stream it.
But you don't have that. Okay, that's
There was one that we dropped.
There's just one on the ground?
Yeah.
Is it? Okay.
Yeah, 'cause we used it for the camera.
No, that would be the paper.
Have we counted lap sponges?
Yeah, I think that's what they're trying to count right now.
Right.
But there was one you put on the ground, right?
Yeah?
Yeah.
There's one that on the ground.
That's good. So they were doing a lap sponge count and one was missing, but it's one that I had used to adjust the camera. That's all good. I think I had done about 7 throws on that. All right, so I'm going to leave it in Hannah's capable hands, and I'll come over and check the stream to make sure there are no questions that have been left unanswered. Rick says, what if we promise to only lightly judge her skin closure? I've made a horizontal incision in the intestine. Why have I preferred that instead of a vertical incision, which is a really good question. Normally I try to go transverse in the intestine, but this foreign body was kind of long, and I was just afraid that I wasn't going to be able to get it out. I'm going to move the camera off. Whoa. And I'll turn it around and face it toward me. Maybe. Hello. Can you guys see me? All right, so I'll just come over here and read some more questions. All right. So a mental patch, that's exactly right. Hi, Nigeria. Flushing the abdomen. So simple continuous suture pattern in the intestine. Single layer is what I do. And I do go through full thickness of the wall because we need to get the submucosa as our holding layer. And still looking Malawi, Dubai. Liver looks good. Best wishes from Texas. Hi, Turkey. Italy, Korea, India, Townsville, and Sudan. Well, it's great to see everybody. I do intend to hopefully live stream tomorrow, but we'll see how many cases we've got. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live.